So we start with the topic macrolides. Now this is one of the group of antibiotics amongst a larger section which you have seen in your books. जो भी एंटीबायोटिक्स दी जाएंगी दे विल बी गिवन अगेंस्ट एन ऑर्गेनिज्म. तो ऑर्गेनिज्म आइडेंटिफिकेशन में ग्राम पॉजिटिव ग्राम नेगेटिव ये आपको आइडेंटिफाई करना है कि जो भी पेशेंट है उसका सबसे पहले कौन सा सिस्टम इन्वॉल्व है, वेदर इट इज सीएनएस, रेस्पिरेटरी, जीआई, यूरिनरी ट्रैक्ट. तो सबसे इंपॉर्टेंट है पहले सिस्टम रिकॉग्नाइज करना विच इज इन्फेक्टेड. सिस्टम आपने पकड़ लिया, उसके बाद उस सिस्टम पे यूजुअली कौन सा ऑर्गेनिज्म होता है, ग्राम पॉजिटिव या ग्राम नेगेटिव. वी आर टॉकिंग ऑफ द बैक्टीरियोलॉजी, बैक्टीरियल वर्ल्ड. वंस यू आर श्योर दैट दिस इज ग्राम पॉजिटिव, तो उसके लिए सेट ऑफ एंटीबायोटिक्स हैं जो कि अब आप लोग पढ़ रहे हो. ओके. एंड इफ यू आर श्योर दिस इज ग्राम नेगेटिव, तो उसमें भी देयर इज अ सेट ऑफ एंटीबायोटिक्स विच यू नीड टू गिव. When you prescribe an antibiotic, जब आप एक डोज दोगे तो इफेक्ट नहीं आएगा, दूसरी डोज लगेगी शाम को या तीसरी डोज लगेगी सेम डे में, तब भी इफेक्ट नहीं आएगा. बट इट टेक्स 24 आवर्स एंड मोर टू सी द विजिबल इफेक्ट इन द पेशेंट. आपने एंटीबायोटिक प्रेस्क्राइब की टुडे 8 AM in the morning. So by tomorrow 8 AM you will come to know that whether you have prescribed is actually correct or you have to improvise yourself. एक सिंगल डोज से ऑर्गेनिजम्स पे कोई इफेक्ट नहीं होगा क्योंकि ऑर्गेनिजम्स मल्टीप्लाई करते हैं एक्सपोनेंशियली. जब ऑर्गेनिजम्स एक्सपोनेंशियली मल्टीप्लाई कर रहे हैं एंड यू आर गिविंग अ सिंगल डोज, वो डोज आपने दिया चाहे ओरल चाहे आईवी, तो वो अभी इतनी इफेक्टिव नहीं है दैट इट कैन किल द organisms. But then when multiple doses are given, then plasma concentration of that antibiotic is going to increase. और जैसे ही plasma concentration sufficient होगी, then that is going to actually kill the organism. So 24 hours to 48 hours is the timeline before you are sure what you have prescribed will work or not. And in polytrauma cases or when the patient is in ICU, every time, every second is critical. Wrong prescription will simply lead to deterioration of the patient. जो patient ventilator पे होता है उसको wrong antibiotic देने का मतलब है that we are losing on time. So this is importance that what organism you have identified and what type of antimicrobial you are going to prescribe. It should cover the organism. So we start with the macrolides. When you look at the history, then we see that this group of drugs is not new one. It is existing since 1980s. तो करीब 40 साल पुरानी दवाइयां हैं, but still they are effective thankfully. So we have to give them judiciously. क्योंकि एक बार रेजिस्टेंस डेवलप हो गया तो वी विल बी लूजिंग दीज इंपॉर्टेंट ड्रग्स. एरिथ्रोमाइसिन, इट्स अ नेचुरली अकरिंग मैक्रोलाइड derived from the Streptomyces erythraeus. What were the deficiencies or problems with erythromycin? It was that it is acid labile, it was narrow spectrum, and it was poor in GI tolerance and short elimination half-life. Similar structure was found with clarithromycin and azithromycin. Here you have a broader spectrum of activity. The gross difference है clarithromycin, azithromycin versus erythromycin में, it is that it has got a broader spectrum of activity. Improved pharmacokinetic properties in which there is better bioavailability, better tissue penetration and prolonged half-life, as well as there is improved tolerability. What is the mechanism of action? It is inhibiting the protein synthesis by reversibly binding to 50S ribosomal subunit that is leading to suppression of RNA-dependent protein synthesis by inhibition of translocation of mRNA. And typically, erythromycin is having a bacteriostatic property. It acts as bactericidal at higher concentration against very susceptible organisms. Here we see in this that these three drugs, one is macrolide, another is lincosamide, and third is oxazolidinones. These three group of drugs which we are going to take today, they are all acting on ribosomal system, that is having two units, 30S and 50S. So they are going to attach themselves to the 50S and prevent the continuation of protein synthesis as well as interfere with the initiation of protein synthesis. So what is the spectrum of action of this drug? Once you have seen that these are the gram-positive organisms, so clarithromycin will be better to give as compared to erythromycin and azithromycin. So the spectrum is methicillin susceptible Staphylococcus aureus, that is MSSA, Streptococcus pneumoniae resistance cases, then Streptococci viridans, Bacillus species, and Corynebacterium species. So this is the gram-positive aerobe coverage which these drugs are going to give. Amongst the gram-negative aerobes, which are more covered by azithromycin, clarithromycin as compared to erythromycin, and it covers Haemophilus influenzae, Moraxella, then Neisseria, and important thing is that they do not have activity against the Enterobacteriaceae. Then amongst the anaerobes which are in the upper respiratory tract and atypical bacteria which have got an excellent activity. So you have a Legionella pneumophilia for which it is the drug of choice. Then you have Chlamydia, Mycoplasma and Ureaplasma. So these are the in particular organism against which this group of drug is going to act. Other bacteria which also it covers is Mycobacterium avium complex, Treponema pallidum, Campylobacter, Borrelia, Bordetella, Brucella and Pasteurella. So clinician lot more depends upon what the microbiology report is. Microbiologists have to identify the organism from the sample collected from the patient, and once the organism is identified, you can give a targeted therapy. Otherwise, you are bound to give a broad spectrum antibiotic which covers more or less all the organism. Once organism is identified, you can give a targeted therapy. What do we see in this? That quite commonly, which we keep on using azithromycin for upper respiratory tract infections, it is having very good response towards different kind of organisms. If resistance develops to azithromycin, agar resistance aa jata hai towards azithromycin, then we will be losing a very, very important drug which was very effective amongst all the organisms. So this is also the reason that why we use azithromycin very rampantly, क्योंकि सबको पता है कि azithromycin का effect सबसे बेहतर है. So give this. There is nothing about it for these organisms. Okay. So the catch is that you have to use the drugs judiciously. What about the absorption? It is for erythromycin, the absorption is variable. Food may decrease the absorption. In the natural base form, it is destroyed by the gastric acid enteric coated. So enteric coated formulations have come in. And for ester and ester salts, more acid stable formulations have come in. And then clarithromycin, this is acid stable drug and well absorbed regardless of the presence of food. And azithromycin, it is acid stable and food decreases the absorption. So why we are saying it should be acid stable? Because you take them orally. जब आप किसी को orally कोई drug देंगे, तो it should be acid stable because the hydrochloric acid which is present within the stomach, that needs to be overcome by the drug. Otherwise वो drug जो है it will get degenerated. So we talk of distribution. Extensive tissue and cellular distribution is seen with these drugs. Clarithromycin and azithromycin, they have extensive tissue penetration, and also there is minimal CSF penetration. Why we need this knowledge? अगर किसी को CNS का infection है with these organism, and you know that these drugs are going to have a minimal CSF penetration, so these drugs will not be effective for CNS infections. Then comes the elimination. Clarithromycin is the only macrolide partially eliminated by the kidney. Hepatically it is eliminated. All the group of drugs are eliminated through kidney as well as liver. None of the macrolides are removed during hemodialysis. Silence. Last people sit quietly or move out. Only two options you have: sit quietly or move out. Don't talk. So you have variable elimination half-lives. One is 1.4 hours for erythromycin, 3 to 7 hours for clarithromycin, and 68 hours for azithromycin. So you can see the half-life of azithromycin is quite long. It is 68 hours. And so we can rely upon a single daily dosing of azithromycin. Then comes the adverse effects. You can see that there are gastrointestinal adverse effects: nausea, vomiting, diarrhea, dyspepsia, and most common with erythromycin they are seen, less with the newer agents. Then there is cholestatic hepatitis, which is, you can see that it is more than 1 to 2 weeks of erythromycin acetylate. Then thrombophlebitis and other toxicities. Ototoxicity, QTc prolongation and allergy. So these are the basic side effects which are seen with erythromycin group of drug. Then there are certain drug interactions. Erythromycin and clarithromycin, they are inhibitors of cytochrome P450 system in the liver. So you have erythromycin, clarithromycin, which are inhibitors of cytochrome P450 system in the liver. That is going to increase the concentration of theophylline, carbamazepine, cyclosporin, phenytoin, warfarin, digoxin, diisopyramide, valproic acid, terfenadine, estimazole, cisapride, ergot alkaloids. So this drug interaction has also to be taken into consideration. If you want to prescribe a good antibiotic, you have to have consideration of what drug interaction it might further create, and that can lead to rather deterioration of the patient. Instead of improving, the patient will deteriorate. So what is the therapeutic use of erythromycin? One is the ENT infection, then tonsillitis, upper respiratory tract infection, mycoplasma pneumonia infection, Legionnaires diseases, chlamydia infection, diphtheria, and then pertussis. So these are the areas where these drugs are going to act. Streptococcus and staphylococcus infections alternatively in the patient allergic to penicillin. Prophylaxis against endocarditis in dental procedures. So there are certain dental procedures in which you further have to give prophylactically these agents. And Campylobacter, Helicobacter infections, where clarithromycin is the drug of choice. In tetanus, in patient allergic to penicillin. So sometimes when patient is allergic to penicillin, then you can give this group of drug, that is macrolide group of drug, which is erythromycin, clarithromycin, they can be prescribed. आप खड़े हो जाए वहां पे दोनों, stand up. Those with the white shirts, stand up and move out. चलिए चलिए बाहर, move, quickly move, move. So you have mycobacterial infections, then clarithromycin and azithromycin, they will be the first choice of drugs. The drug of choice for Mycoplasma pneumonia, Legionella, Chlamydia, Bordetella, Corynebacterium will be erythromycin. Now this erythromycin, which was discovered in 1950s, is still the drug of choice, and this is very thankful that the infections associated with it are still being cured. So new macrolide antibiotics, what are the advantages of the newer ones? That is, they are broader spectrum, orally they are effective, they have got a higher blood concentration, and they have got a longer T half-life, less toxicity, and mainly it is used in the respiratory tract infections. Strongest activity against, now this is something about azithromycin, which we quite oftenly prescribe and take it in any kind of viral infection, although we should not take it. But still, this azithromycin has been used, or I would say it is misused for ages under the viral infections. It should not be used. It should be given only when there is bacterial infection that is suspected. So it is having the strongest activity against Mycoplasma pneumonia, less effective against gram-positive bacteria than erythromycin and clarithromycin, more effective on gram-negative bacteria such as Haemophilus influenzae and Legionella. Excellent action against Toxoplasma, and it is well tolerated with a T half-life of 68 hours, mainly used in respiratory tract infections. So, prolonged and persistent good concentration is seen within the cells, and 3 to 5 days therapy is what we give. और किसी को जाना है by wish, कोई बाहर जाना चाहता है? Anyone who wants to go outside by his own wish? So you have a pregnant woman infected with scrub typhus, उसके अंदर भी जो है ये एक substitute बनेगा to doxycycline. Now doxycycline is a drug which is teratogenic, and so you need a substitute. Herein comes the erythromycin, which can act as a substitute to doxycycline, especially in the cases of pregnant women suffering from scrub typhus. Scrub typhus in Rajasthan is quite common. If you move into the ICUs, you will see patients who are suffering from scrub typhus. So next is clarithromycin. That is, it has got the strongest activity on gram-positive bacteria, Legionella, Chlamydia, and Helicobacter pylori. Then it has got a good pharmacokinetic property, and it has got low toxicity. Uses are atypical mycobacterial infection, resistant leprosy, toxoplasmosis, and H. pylori-induced peptic ulcers. So you have read about peptic ulcers. In that you have read about that there is a therapy, that is 3-drug therapy, combined therapy, which you give for removal of H. pylori. So one of them is clarithromycin. And in fact, in tuberculosis, stay outside, bar. So what we see in tuberculosis, which is caused by atypical mycobacterial infection, which is actually known as MAC, therein clarithromycin is given. Another newer agent is roxithromycin, which was developed in France in 1987, and it reaches highest blood concentration. Bioavailability is up to 72 to 85%. The respiratory tract infection and soft tissue infections, it is going to cure the respiratory tract infection and soft tissue infection, and there is a lower adverse effect. Roxithromycin is not frequently used in the clinical side. What frequently used is clarithromycin, azithromycin, and erythromycin. We are trying to conserve this roxithromycin for future use, just in case resistance comes to the azithro, clarithro, or erythromycin. Doses: erythromycin given 1 to 2 gram per day divided into 4 doses, clarithromycin 250 to 500 milligram twice a day, and azithromycin 500 milligram per day. So this was all about the macrolide group of antibiotic. These are the drugs which were discovered quite long back. Thankfully, they are still active against concerned microorganisms. And the best part is, whenever we need an alternative, suppose a person is having allergy to penicillin group of drug. Now what to give? We are shifting to macrolide. So it's a substitute, a good substitute to the penicillin group of antibiotic. Then comes your miscellaneous antibiotic. Herein you have a clindamycin, which is similar in mechanism spectrum to erythromycin, exhibit partial cross resistance. Spectrum that it is going to cover is Corynebacterium diphtheriae, nocardia, actinomyces, toxoplasmosis, and variety of other anaerobes. When you look at the pharmacokinetics, it is orally absorbed and it doesn't penetrate the brain and the CSF. Adverse effect is, when you are prescribing clindamycin for a longer time, it causes Clostridium superinfection. It is going to stop. Then in that case, you need to stop the drug. Other side effects are rashes, urticaria, and abdominal pain. So what are the uses of clindamycin? It is first-line drug to be used in anaerobic and mixed infection. Sometimes when you sit in OPD, you don't understand कि X-ray में तो दिखेगा that there is white opacity. White opacity का मतलब कि उसमें कहीं ना कहीं निमोनिया का फीचर है, बट आपको ऑर्गेनिज्म पता नहीं है, you don't know the organism, then you prescribe clindamycin. Okay, because it is going to cover anaerobic and mixed infections. So in case of pneumonias, usually in OPDs you will see that clindamycin is being prescribed. And also it is used when patient is allergic to penicillin, then also used in toxoplasmosis along with pyrimethamine, then in multi-drug resistant falciparum malaria along with quinine and artesunate, and it is used topically for acne. Another group is glycopeptide antibiotic, which is consisting of vancomycin and teicoplanin. Now these group of drugs, whenever you move into the ICU, you will see that patients are on vancomycin or teicoplanin. So what does this group of drug do? That is, glycopeptides, what they do? They are going to basically inhibit the cell wall synthesis. So they are having principally bactericidal effect. And this is the mechanism by which they are going to kill the bacteria. What is the absorption? See here, you have oral formulation available only for vancomycin, not for teicoplanin. Teicoplanin is always given IV. But vancomycin, which is used to treat gram-positive bacteria, especially Macrolide-resistant Staphylococcus aureus, their oral formulation is available. That is, vancomycin is the drug which can be given orally. And if you talk of IM preparation, then that is intramuscular, then it is the teicoplanin which can be given. So it all depends on the setting in which the patient turns up to you. If you are in a OPD setting, you require something which can be given orally. If you are in a IPD setting in hospital, then you require something IV which you can give and quick response can come. So this you have to see what we can give and what we can't. When we talk of distribution, here you see that it's quite wide, permeates inflamed meninges and serous cavities. So this is the best part why the CNS infections, they are treated with vancomycin. क्योंकि vancomycin जो है इसका distribution wide है, it is going to permeate through the inflamed meninges and serous cavities. So in the neurological department, neurosurgery especially, you will see maximum use of vancomycin because it can penetrate the inflamed meninges. And then what is about the elimination? It is largely unchanged by the glomerular filtration rate. Whenever there is a chronic renal failure patient, you have to reduce the dose and carefully monitor for any renal toxicity. T half-life of vancomycin is 6 hours and teicoplanin is 3 to 4 days. Adverse effects, ये important है. You should know that vancomycin is quite rampantly used in the neuro departments and there are adverse effects: ototoxicity, nephrotoxicity and red man syndrome. So it is also said that go for therapeutic drug monitoring of vancomycin. That means whenever you are prescribing vancomycin, you got to get the blood levels attained in the blood levels of vancomycin attained in the plasma that need to be monitored because of the toxic nature of the drug. So what happens in red man syndrome? Because of histamine release and hypotension and chills, there is intense flushing and it occurs on rapid IV injection. This red man syndrome is not seen with teicoplanin. So if there is a patient who has got allergy towards vancomycin, then you got to prescribe teicoplanin. So this is the way you got to handle the patient with whatever scene and scenario he is presenting to you. This is the spectrum of action of this group of glycopeptide, that is vancomycin and teicoplanin. Gram positive, it is going to treat the Staphylococcus aureus, Staphylococcus epidermidis, Staphylococcus groups A, B and C, Staphylococcus pneumoniae and Enterococcus faecalis. Then gram positive bacilli, it covers Listeria monocytogenes, Corynebacterium. Then there are gram negative cocci and gram negative rods. Amongst the anaerobic organism, there is Clostridium species, spirochetes, mycoplasma and chlamydia. So whole lot of list is there. Specifically, you have to give the drug and monitor whether improvement is there or not. And microbiology will help you, will support you in identifying the organism. Many a times it is seen that you prescribe the drug and when you go on round, there is no benefit to the patient. So then you have to clinch upon your IQ now what to give next. Because microbiology may suppose the report is negative, that means no organism found. But that doesn't give a full conclusion कि माइक्रोबायोलॉजी में कोई ऑर्गेनिज्म नहीं आ रहा है, इसका मतलब आप ना विजडम यूज नहीं करेंगे और कुछ भी नहीं देंगे. You have to use your brain, you have to give something which is of useful to that admitted patient. Then there are certain multi-drug resistant organisms. So vancomycin extensively used in surgical prophylaxis, and it is now past 5 to 10 years, lot of development of vancomycin resistance has taken place, that is vancomycin resistant Staphylococcus aureus. Staphylococcus aureus जो बैक्टीरिया है उसका नाम चेंज करके क्या कर दिया, vancomycin resistant Staphylococcus aureus. So this is kind of Staphylococcus aureus is resistant to the vancomycin group of drug, and there is vancomycin resistant Enterococcus. So actually bacteria, they are live. As we modify ourselves accordingly, so bacteria also modify themselves accordingly. आप कोशिश करेंगे to kill the bacteria, but they will try to protect themselves. And in that war between us and the bacteria may also win. अगर उनको protective mechanism मिल जाता है, तो your drugs will become ineffective. Then teicoplanin is active against some of the vancomycin resistant Enterococcus, but not against the vancomycin resistant Staphylococcus aureus. Enterococci, they are quite susceptible to teicoplanin. So what are the uses? When you look at vancomycin and teicoplanin, the uses are the same except the pharmacokinetic property that vancomycin is available orally and teicoplanin is not available orally. So vancomycin, they can be given in antibiotic associated pseudomembranous enterocolitis as a second choice of drug, then in Staphylococcus enterocolitis, then as a surgical prophylaxis, then in serious MRSA infection, then enterococcal endocarditis, bacterial meningitis as an empirical therapy, then in serious skin soft tissue infections as an alternative. So this is a wide spectrum of antibiotics you will be reading, wide spectrum of microorganism coverage also you will be reading, but you have to use your wisdom to analyze what is best for the patient at that given point of time. Then comes the another group, that is oxazolidinones, linezolid. This is again another important drug which is used maximum in OPD. Any drug which formulates as oral वो OPD में बहुत तेजी से prescribe होने लग जाती है. So linezolid, which is a synthetic drug and it's bacteriostatic in its action. Mechanism of action is it binds to 23S. Last white shirt, खड़े हो जाएं in the middle. Move out. चलिए. So it binds to 23S fraction of 50S and it distorts the tRNA binding site. It inhibits the protein synthesis. और जाना है किसी को इनके साथ? Anyone else amongst that group? और जाना है? So you have oxazolidinones where you have the pharmacokinetics rapidly and completely absorbed orally, partly metabolized and partly excreted. There is no dose modification in renal insufficiency. So this is again an important point, that you have an antibiotic which can be given orally, which does not require renal modification. So this is something important, क्योंकि there are patients of chronic renal failure, उनको आप क्या दोगे? You have to modify the dose of the drug again and again, because chronic renal failure में staging होती है, grade 1, 2, 3, 4, 5. जैसे grade 5 आएगा तो you have to give a modified drug dose. Therein, the best part of the linezolid drug is that there is no dose modification required in renal insufficiency, and you can blindly give the standard dose. Then what are the side effects? There are certain GI side effects, nausea, diarrhea, abdominal pain. Then there is myelosuppression, neutropenia, anemia and thrombocytopenia. Prolonged use is going to monitor, you have to monitor full blood count closely. Optic neuropathy, if the drug is given for more than 4 weeks, then there is a chance of optic neuropathy. And then you have some monoamine oxidase inhibitors with which the interaction is also possible. So this is a spectrum of the drug coverage. You have gram-positive cocci, then gram-positive bacilli, then you have anaerobic organisms, Clostridium, and then Mycobacterium tuberculosis. So once again, the coverage is of both gram-positive as well as gram-negative. And the use is single spectrum is large and is available orally, so used in a non-serious cases. Valuable drug, it should be reserved for future use. It can be used for serious hospital-acquired pneumonia, febrile neutropenia, wound infection, and other infections suspected to be caused by multi-drug resistant organisms. Amongst the endocarditis, which are of serious nature, then it can be used, but it will be kind of bacteriostatic. जहाँ पे हमको एकदम से quick action चाहिए, so we should use bactericidal drug. If you use bacteriostatic, so quick action will not be visible. Another group is quinipristine and dalfapristine. Here you have synergistic combination. Here you have synergistic combination that is going to inhibit the protein synthesis and active against most of the gram-negative, gram-positive cocci, including the MRSA, VRSA and VRE. Uses serious nosocomial MRSA, VRSA, VRE and other resistant gram-positive infections. हाँ आप खड़े हो लास्ट में, खड़े होइए लास्ट में, हाँ हाँ दोनों खड़े हो। ये क्या है? MRSA क्या है? VRSA, VRE, आप बताओ VRE। So use is the serious nosocomial MRSA, VRSA, VRE। और जाना है किसी को बाहर? जाना है? ओपनली कह रहा हूं, आपको जाना है तो चले जाएं। So you have these group of organisms. Mupirocin, very commonly used topically antibiotic given, that is T-BACT। चलिए उनके आगे जो है दोनों जने खड़े हो जाइए, मूव आउट, मूव आउट। जो खड़े हैं उनके आगे दो जने हैं वो खड़े हो और बाहर निकलें। मूव आउट। So this mupirocin is available only topically, and the mechanism of action is it enables the protein synthesis. Spectrum, it is gram-positive bacteria that it is going to cover. And then you have the use, that is in infected insect bites, so you have infected insect bites, small wounds, folliculitis, impetigo, and furunculosis. Now these are some of the skin infections for which we prescribe the topical antibiotic, that is mupirocin. And you have the adverse drug reaction, that is local itching, redness, and irritation. Dose given thrice daily. Polypeptide antibiotic जो है polymyxin B, colistin, and bacitracin. Now these three agents is given almost to every alternate patient in ICU. Whenever you will be moving in ICU, ये तीन दवाइयां आपको every कहीं ना कहीं alternate patient में मिलेगी, इनमें से कोई सी भी तीन. So this is polymyxin B, colistin, and bacitracin. These are higher end antibiotics which we should keep as a reserve. They have got a powerful bactericidal drug, and mechanism of action is that it causes cell membrane distortion and pseudopore formation. So as a result, the ions and the amino acid, they are going to leak out. Spectrum of coverage is gram-negative bacteria except Proteus, Serratia, and Neisseria. So adverse effects are nephrotoxicity and neurotoxicity. Because they are having nephrotoxicity, they are having neurotoxicity, so we try to conserve these drugs, and they are finally, when nothing else is available with us, we have to give these kind of polypeptide antibiotics, that is polymyxin B, colistin, and bacitracin. So we end here.